My name is Anahita Dua. I'm a vascular surgeon over at the Masschusetts General Hospital in Boston and an associate professor of surgery at Harvard Medical School. I'm the director of our Peripheral Artery Disease Center. Over the last 30 years, patients that have abdominal aortic aneurysms have been fully repaired if they're getting an endovascular repair by going through their groins, because the stent needs to get to the infrarenal abdominal aorta. And in order to do that, literally the only pathway that any of the four big stent companies have used to get the stents into the body have been through the actual femoral arteries on both sides in each groin. And that's fine and was fine for 30 years. But the problem is that nowadays patients are living longer. They have diabetes, they have coronary artery disease, they have peripheral artery disease, and this adds this horrible layer of calcium to their blood vessels. And so the standard devices are simply too large to fit into a lot of our patients safely, especially in Asians and women who have smaller blood vessels to begin with. We created a device called AxSES, A-X-S-E-S. It's kind of a play on the word axillary and access. Why? Because we use the axillary artery or the arm artery to enter the patient's body and ultimately get to the aneurysm and fix it. Now, this is really cool because, first of all, we've been able to design a stent that is 40% smaller in its delivery system than any of the stents on the market, without compromising the actual neck of the graft. I see this problem every single day. I suffer through this problem every single day, and so do my patients. So I already had the idea that wouldn't it be nice if we could come with something smaller, sleeker, through a different portal in the body. And as we already know, in 2026, the cardiothoracic surgeons, the cardiologists, and of course the vascular surgeons are using arm access for all kinds of things. We're doing complex aorta through arm access. We do TAVRs. We do all kinds of mesenteric stenting. We do PAD work through the arm. We certainly do CATs. So why can't we also do EVAR? That's where my mind was at. So what I did is teamed up with actually kind of the trifecta. I'm a doctor, obviously, but the other co-founder is an engineer, and the third co-founder is a lawyer, because that's what you need when you're doing a company. You need your IP protected. You need the engineering because the R&D needs to be perfect, because patients need to have a safe, durable option. And of course, you need the doctor to say what's clinically appropriate. So after the three of us got together and created something, we did our acute animal studies, which showed that indeed we had a nice working prototype. We did talk to the FDA. We've already had our informational meeting with the FDA. And now the next step, of course, is something called the Q-Sub, where we actually kind of lay out for the FDA what the next steps are in terms of our chronic animal studies, fatigue testing, and ultimately first in human. There have been multiple instances where the major stent companies have created smaller profile stents, but they just haven't really been durable. They just haven't really worked. And the reason for that is, in the same way that a child is not just a tiny adult, there's different physiology, it's a different situation. Making a smaller stent is not just taking the standard stents that exist and miniaturize them. You have to completely redo the engineering. And frankly speaking, of the four major stent companies that are out there, only two of them have an R&D department, and most people who are in the aortic space are interested in conquering the arch. This device, in my opinion, will save lives. The reason is because, honestly, again, I mentioned earlier that I'm the director of our Peripheral Artery Disease Center. So, you know, the standard vascular surgeon of today might say, well, what does that have to do with aorta? Everything. It has everything to do with aorta, because the peripheral artery disease patient that gets that aneurysm is exceptionally difficult to treat, because there's calcium all over the place in terms of their distal, in the bifurcation into the iliacs, into the femorals. And so it is a challenging, hostile groin through which you have to make your way on both sides in order to deliver your device and then safely remove your delivery system without causing, quote unquote, iliac on a stick, where you rip the whole thing out, injuring the blood vessels, causing thrombosis, things of that nature. Of course, as I mentioned, you know, the Asian population that already have small blood vessels to begin with, then you add to that calcification. And then the same thing with the women. So what's interesting, you know, is that there are a number of market leaders in the aortic space, and they have conquered the world. But the one market that has been really unconquerable at this point is the Asian market. And the reason is because our devices are simply too big. I think the most important thing in the small anatomy stage to begin with is recognition of it. You know, there are many problems in medicine. Nothing that we do is absolutely perfect. But I think a lot of times what we do in medicine is say, well, it's good enough. So there is a better way. But then what happens is in the medical world, we say, well, you know what, 80% of the time it works enough. So let's just let it be. And that's not okay because in the case of aortic aneurysms or in the case of PAD, the sheer volume of patients that exists, if you said, I'm just going to let 20% suffer or 20% not get care or 20%, get subpar interventions that can lead to death, that 20% is actually hundreds and hundreds of patients. So it is important for us in medicine to keep iterating and getting better and better. But when you iterate, you don't need to take what already exists and make that better. You can break from that and conceptually do something different.